Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory.
So moving on to established biliary structure. So you mentioned in your time in SGPGI, you authored what we all know is still remains one of the largest single center series on post cholecystectomy bile duct injuries. So can you take us through the process of what led to these seminal publications, especially the Sikora modification of the Bismuth grade 3 classification? I mean, it's on everyone's fingertips, we know. So how did that come to be?
So that was our first publication, actually.
Mm. Mm.
I think it was in 2003,
2003. Yeah.
something like that. So that was our first publication, and when we are doing these bile duct injury repairs, we realize that there are types or
Mm.
various sort of phases of high strictures that we encountered.
Mm.
Some were
Mm.
very neat with a bulging duct and, the right, left communicating nicely. And where one was happy.
Waiting to be opened.
Oh, yeah, one was happy that, oh, great, this one is a good duct to anastomose. And then others were there where there is a strictured area, you're not sure whether there is a communication, the roof is intact maybe, but it's not like bulging kind of a thing. And we realized that in those ones, you need to sort of freshen the edges. So instead of, it would be a modified kind of end to side
Mm.
anastomosis. Because generally we would prefer doing a side to side
Right.
catechogenostomy in most of the scenarios, except the type 4 ones where
Mm.
you have the end ducts.
Separation. Mm.
Yeah. So we realize that these are a little different, types of strictures. And when we had enough, we analyzed that and said, so the good part about SGPGI and Professor Kaushik was his seminal contribution, apart from anything else for surgical gastro, was to inculcate in this department the idea of audit and data keeping and
Mm.
data analysis. And that time, I don't know whether you remember 1990, you were school, school.
I was, yes,
Yeah.
preschool maybe. Or yeah.
Okay. So there were no computers. Computers had just come. The
Mm.
database maintenance, there was a separate software and all. But the residents were given responsibilities and we maintained very meticulously all this data. Then we had a data operator who would put it in. So the data was very robust.
Mm.
And we had follow-up cards. We used to fill in the outpatient and come back and update each resident. One faculty was assigned for a area like gallbladder cancer, bile duct injuries, so like that. So they were designated responsibilities. So we had this data. And then when we reached a sort of critical point of around 300
Mm.
strictures, we said that, it's time that we write about it because whatever what we were getting, I mean, we can't complain about that. But whatever we got, the results were quite impressive
Yeah.
by all comparisons, with a failure rate in single digits of 5% or something like that. So you granted that majority were type 2 and type 3 in that.
Mm.
But whatever it is, at that point, we thought it was a great experience to report. And that's how it came about because of the fact that we had good data and everything was
Mm.
there. And then subsequent other things, I'm also very happy about this liver biopsy, because that's
Mm,
one thing which we have found that, grading of outcome can be misled if you follow the regular LFT and HIDA scan,
mm,
which were being recommended by the McDonald's grading and Bismuth's group, um, your uh, Blumgard's group,
mm.
the way of assessment. So we found that if there is fibrosis, the liver functions don't remain normal. You will continue to have an elevated SAP and GGT, you know. So if you know that, then you know that it is not
A
bad outcome.
problem, technical.
It's
Yeah.
just the so we segregated into B1 and B2 of
Mm,
the type. So I think if you have good data, you can do a lot of analysis and design also a lot of research projects around that. So I
mm,
think audit and data was what led to all these publications.
mm. So, if what is your typical decision-making procedure? So, a patient comes with a established post-cholecystectomy structure. We talked about how long you'd wait, but otherwise, what factors weigh in when you decide on how to proceed? Any red flags that you look out for? Just can you take us through your process?
So I'll make an abbreviation ATC:
Okay.
anatomy, timing, and condition of the patient, right?
Okay. Mm,
Anatomy, of course, is important because now it's an established injury and you need to know what the anatomy is, because your thought process of what procedure to do, how to approach that will differ. So,
okay.
up to type 3, there is a certain approach to that. And beyond type 3, you need to look at other things. So, that anatomy is important. And sometimes we get internal fistula, then atrophy, hypertrophy, all these things you
Mm,
need. The timing is important, as you and we have discussed, that it has to be a delayed uh,
okay. Mm,
repair. And this delay depends also on the course of the post-cholecystectomy course of these patients. So whether they needed multiple catheter insertions,
intervention. Mm,
whether they were having multiple episodes of cholangitis,
mm,
whether um, the there was an internal fistula which was leading to cholangitis. So, the longer the duration also, I remember one patient, uh, the mortality rate in that was around 1.4. Some 4 patients lost. One patient I remember we lost, and we operated that patient after a long period of time for
mm,
3 or 4 months. But that patient was malnourished, patient had
mm,
vitamin deficiency, coagulopathy, and that patient didn't do well post-operatively and went down. So you need to look at that longer the duration, you have problems of the
nutrition. Yeah.
nutrition,
Mm,
uh, fat soluble vitamin deficiencies,
okay.
and also portal hypertension, development
Mm,
of portal hypertension, which you have to remember that.
mm,
So timing in that sense is important. And as I said, condition of the patient, because if there is ongoing recurrent episodes of cholangitis, nutrition is not, you may postpone it a little longer and wait for it, you know.
mm,
So these things are important. Of course, the sepsis is very critical. That's a red flag,
mm,
because I would not suggest attempting a repair in the presence of sepsis. So you need to be careful, and if you need to drain a system or make sure that there are no other areas which are undrained, you need to take care of that. And the other thing, if it's prolonged, is atrophy, hypertrophy. Because if
okay.
that develops with a vascular injury and there is atrophy, hypertrophy, then the considerations are very different. So that's a red flag again.
Mhm.
And
Mm,
of course, the recurrent strictures or HJ strictures are a different
ball
ballgame.
game.
So
Okay.
That's how I go about assessing and planning what would be required for uh, complex stricture and the sort of type 1 to 3. If you get, it's a different approach.
So, coming to the meaty portion of our discussion. So, what are your introp strategies? So, one, identifying a difficult duct, safeguarding the artery. Are there any critical nuances that you feel may be overlooked by some less experienced surgeons?
What I think is critical to identify ducts is to study the anatomy the cholangiogram, MR cholangiogram, very, minutely and carefully,
Mm.
because that is going to make the difference between a good repair and a bad repair.
Okay.
We all know, I mean, all people HP citizens that left duct doesn't get injured in lap chole, and that's a very, it is always present in a particular location. It is constant, consistent, and has that horizontal portion,
Mhm.
barring some variations where it is a little vertical. So, if you are doing a or looking for a duct, that place after lowering the hilar plate under segment 4 is the place to look for the duct, right? Uh, Sometimes it may be difficult if it is undilated and you have had to operate earlier, then it may be difficult. But actually, undilated scenarios would be associated with either an internal fistula or an external fistula. So you can trace the fistula and reach the duct in
Mm.
that situation. So duct finding, and I think now with ICG cholangiography, which we have now understood, that may also be a source or technique to sort of target or identify a duct if it is problematic to identify.
And
I'm not very concerned about the artery. I mean, I don't go looking for the artery. That, oh, where is the artery and let me preserve it. Because, going for that may be a problem. Uh, if it is coming anterior, it has happened a couple of times
mm.
that there is a stricture and there's coming anterior to that, then you need to mobilize to do a good repair. I think some of the things which people may not concentrate on when we are doing biliary stricture is that you should have your approach should be to cone into the hilum rather than dive into the hilum.
Mm.
So when I say cone end means you go from the lateral part, subhepatic area where the dissection is easier and you're not going to injure any structures. We sometimes miss doing the left-sided dissection. That is
Mm.
also equally important. And of course, the liver mobilization. Because all this, what happens is you can sort of bring the hilum in front. So
Mm.
coning from all sides, that is important. One of the things I learned is lowering the cystic plate also helps.
Mm.
We talk about lowering the hilar plate, but you have to extend that on the right side also and lower the cystic plate because then it makes life much more comfortable and you can get to the right duct
Right.
also, which
Mm.
we used to believe that it's intrahepatic, but there is a good segment which is extrahepatic. So that's the second thing. And I think you need to have a good exposure of the duct with the healthy duct to be exposed and do a wide, good anastomosis, which you should be able to accomplish if you have fulfilled all these, uh, you know, ticked all these boxes that I'm talking
Mm.
about during dissection. Um, we often forget the other hand, which claps, which is the jejunal loop. So,
Mm.
I mean, preparing the jejunal loop is equally important because If it is under tension, if there is congestion, that means venous congestion also, it's not a good loop to. It should be soft, supple, and reaching the hilum without you trying to pull it. And once you get the shortest route to be
Mm.
retrocolic. So if you take care of both these things and do a good anastomosis, it should be it should work in most cases.
And I'm very confident that every audience member would agree that you are a master in this field. But when and how long did it take for you to master the surgery? I mean, was it in terms of a learning curve or number of cases or complexity of cases for you to say, I can, I can handle this?
Yeah, so I think you need to. I mean, seriously, I think you can't ever say you have mastered it because there will be something which will come up and it'll test you again that what you need to do. So, for example, I had a patient who had pancreatitis
Mm,
and bile duct injury, right? And we had
mm.
to do the repair. So we went and getting prepared to do the repair. And I realized that getting the rule loop up is a tough
Nightmare. Yeah.
task. I couldn't. I mean, I realized we couldn't take it up because the mesentery, the colonic mesentery was shortened. The whole mesentery otherwise was shortened. And there was a big guy. So we had to sort of modify it, and I made a tube out of the stomach, greater curve of the stomach, and then
Use
did
that as a.
osmosis to that. And it was vascularized with the gastroepiploic, but it was opening into the stomach. So that was the
Mm.
compromise you had to make. So challenges will continue to happen. But as I said, I I like to say that all the things which I mentioned, but in a very orderly manner, that expose the duct well, lower the plate, ensure that all ductal systems are identified and drained, especially if it is a complex hilar stricture.
Mm.
Look after the jejunal loop, and it should not be under tension. And I realize now that doing anastomosis with loop, with fine uh, monofilament sutures gives the best result. You won't believe we used to do anastomosis with silk in SGBGI in the beginning.
Really? Yeah.
Yes, we used to do with silk. And then we went to Vicryl 2030. And then, of course, now we all know that it's a monofilament. I mean, the only fact is that despite that, there were not
You
many.
still had a 5% stricture rate.
So maybe it doesn't matter.
So, just to complete the discussion, when would you consider a liver resection? When just a head J won't cut it?
Yeah, so, I mean, if you read the publications which we have had and from SGPGI about atrophy, hypertrophy, and these things, the number of patients undergoing liver resection is not many,
Mm,
right? So
mm.
our approach is preserve the parenchyma as much as we can and do the anastomosis. And I've done even in an atrophy, hypertrophy situation, as long as I can drain the atrophic segment well.
Okay.
But having said that, there are certain situations where I would consider liver resection. And one of them is that if there is a complex hilar injury with vascular injury, which is
Mm.
the hepatic artery, then it may be worthwhile to do a hepaticojejunostomy. It could
Liver
be
resection.
in recurrent stricture, oh, sorry, liver
Liver.
resection. Recurrent stricture with atrophy, hypertrophy, then hepatectomy
Resection.
may be
Mm.
better. Acute scenarios is something where theoretically you may be required to do it, but I've never encountered that wherein, as I said, that scenario that there is
Necrosis.
a
Oh,
ischemia of the liver, there
okay.
is bile duct injury, and you have no choice but to resect the ischemic liver, and then see you do a hepaticoagenostomy as best as you can.
Okay. So we know that to survive, you need to constantly reinvent yourself and evolve with the times. And you've done that brilliantly. I mean, anyone who's seen you operate know you can, equally do well open, lap, and now robotic. So, how has minimally invasive surgery, has it changed your approach to biliary stricture management, or you think there's any role for a laparoscopic approach to these patients?
So, I mean, I think a lot of times people have skepticism because of their own shortcomings,
Okay.
right? So I used to think that, you know, minimal invasive repair is compromising the best
Quality
opportunity to repair, because we know that the first attempt at repair is the
is the
best
best.
opportunity to repair. And you don't want to lose that
Yeah.
because you want to foray into something, right?
Mhm.
But with, if you are experienced, you are confident, I would still choose the patient well. I
Mm.
would not even now say that for a complex stricture should do a minimal invasive repair. So up to a good type 3, type 1, type 2, and good type 3, nicely chosen cases with dilated ducts so that the technical part of the procedure goes off smoothly. Uh, Complex strictures is a different area, and
Mm.
I feel that there's a lot of things which need to be done by directly being there, and minimal invasive may not be the best way to go in that. So I have accepted that in a select group of bile duct injury with strictures, you may offer these patients minimal invasive. And if you ask me, I would prefer robotic because I'm not all that adept at fine suturing laparoscopic, but with robotic, that can be, you know, overcome.
Mm. And technical considerations apart, like we've touched upon, are there any other strategies you suggest for minimizing recurrence of strictures, like stenting or uh, percutaneous access, or any other strategies, especially for complex
Yeah.
strictures?
Yeah, that's another thing which I'm very happy and satisfied, I feel, about this, the complex strictures. Uh, I think there's a well-devised strategy which we have developed over all these years with inputs uh, from SGPGI and other discussions. And I think you're a co-author in
Yeah.
that. We've published in Indian Journal of
Mhm.
Surgery. So I think, again, anatomy assessment is important. Once you get into the realms of high stricture, multiple ducts, and type 4 or type 5 strictures, then you need to have a strategy for that. The strategy is that you need preoperative cannulation of a duct which is most lateral so that you know which area to work in to identify other ducts. You can, if it is a complex stricture and you find that there are multiple ducts which you may have to anastomose, then I would cannulate all the right ducts, the anterior and posterior, because this is one scenario where you may want to use stents. Normally, I
Mm.
would not use stents in bilioenteric anastomosis. But these are scenarios where you may want to use stenting. And stenting means long-term stenting. And what we have suggested now is that not only do you do stenting, which is transhepatic, transanastomotic, but you preemptively deal with them to ensure that there is a good stoma by dilating these anastomotic areas with balloon preemptively in a
Okay.
very well laid down protocol that you
Mm.
do it every so 3 to 6 weeks post surgery. In those in which we've seen that it's a difficult anastomosis,
Naturals.
likelihood of stricture is high, we have stented. We just don't leave the stents. We start ballooning them after about 3 to 4 weeks or 6 weeks.
Yes. Mm.
We balloon it till we find that it is you don't have to put any force, there is no waste, and there is easy dilatation of that. Leave the catheters after that for a period of 6 to 12 months. Reassess at that time, and then only then remove the percutaneous catheters. So, Gayatri, what it does is that you don't have to wait for fibrosis to occur and then you are dilating. You are
Mhm.
ensuring the stoma when it is supple and
Yes.
malleable. So
Mm.
you sort of make
Can
sure
I?
that I want this diameter of the uh, anastomosis or stoma to be there.
Yes.
And you
Mm.
do it early. And you ensure that you give enough time for the healing and all to mature so that you know when you remove that this is the final diameter or status of the edge that you will get. And once you reach that point, then you can remove that. So, with that, I think we've realized that we can obviate or prevent stricture formation
Okay.
after a hedge. So
Mm.
it needs to be done and experienced by very many people. But I think it sounds very logical to me, and I'm sold out on that. And
Mm.
hopefully, many other people would take that or may improve upon that. I don't know how it will evolve with
Okay.
further times.
One thing I've always felt dealing with these patients, um, even though it's not malignancy, it can be equally debilitating to have this condition. I mean, it's an iatrogenic complication. You went in for a routine procedure, and now you're dealing with something that's going on months on without end. So, how do you deal with the psychological impact with these patients? How do you counsel them for the long road ahead, especially complex injuries, potentially multiple interventions? How do you deal with patients?
Yeah. Yeah. See, of late, I've realized with the way we have evolved how to treat these strictures that most of the cases we would be able to find a solution for them. But the thing which is lacking in these patients because of what they are going through is patience. They want quick solutions. And sometimes the impatience of the doctors also contribute to uh, uh,
Unfavorable outcome.
un-
Unfavorable outcome.
unfavorable outcome in these patients. So
Mm.
I tell them, I make them sit and tell them that you've had a problem. It is known, but now having had this, you need to deal with it. We can provide the solution, but you will have to be patient. That counseling takes me almost half an hour or so to generate the confidence that we will be able to resolve the issue. And the second part is that they have to be follow my timelines and not their timelines. And
Long
it's
haul.
not easy. Yeah, it's a long haul. It's not easy to convince them. And if uh, somebody offers them a earlier quick fix solution, they are tempted to do because they won't know any better. So
Mm.
I tell to all my colleagues that, you be patient. However much the patient is in trouble, deal with the problems, but don't rush to repair at intermediate time. And I sort of assure them, although we can't assure in these scenarios, but depending on the anatomy, I give them that assurance that at the end of the day, you'll get back your full, normal, good quality of life, getting back to work. And that assurance we can give based on what we have seen over all these years. So
Okay.
uh, it's a tough thing for the patient. I realize that. And we need to uh, have a multi-dimensional approach to their treatment, and psychological support is equally important, not only for the patient but for the family also. And we should not forget the surgeon, who has
The primary
who
surgeon.
has uh, nobody does it intentionally. So there's a price the surgeons have to pay if they encounter a bile duct injury, but that's some other time. And we can't forget them, and they need support equally.
So, mm. So, speaking of convenient solutions, any thoughts on endoscopic management of biliary strictures?
The easy answer is no. I don't think it has any role. But there are certain scenarios where I think endoscopic treatment is useful and can be accomplished. It is also a long procedure. The procedure are multiple and long, as opposed to surgery where waiting period is long, but we try to do it in one
Mm.
procedure. But I'm excited about some other things. What excites me is, you know, we talked about the landscape, how it has changed. So at
Mm.
that time, endoscopic interventions were not that well developed. Now, with that, a lot of bile leaks, lateral injuries, these can be dealt with.
Mm.
Those with some continuity can be dealt with. And simple strictures or ischemic strictures with no loss of length can be dealt with endoscopically. And I think with evolving, available technologies of retrievable stents, absorbable biliary stents, the magnetic button
Mm. The
technology,
anastomosis.
I think for edge strictures, it might be a
Game changer.
fantastic thing. Uh, so there are endoscopic methods available, but the bottom line is you need to choose.
Mm.
You need to be able to choose the patients for the procedure, not the that you know impose the procedures on the patients.
So, yeah. So, not just about biliary surgery, but I have to ask. Um, you're a wonderful teacher to many generations of surgeons, and how has teaching enriched you? How has it, been as an experience having trained so many surgeons over the past decades?
It's an elixir of life. So I mean, surgical life. Without that, I don't think uh, it would have been such a good journey. You know, I mean, the ability to share your experiences and to see people grow who have had the opportunity to be with you is a real, different pleasures that one gets from that, and satisfaction, fulfillment you get from that. So I always feel that that's something which has kept me going, and it works both ways. It works hopefully for the people at the receiving end, and
No
it
doubt.
works for me.
So, what is your advice for professionals working outside of a teaching institution? How do you still stay focused and interested academically?
I think, it is something which adds to your uh, value as a surgeon for yourself and for your patients. So I think you need to realize the value of that. Once you realize the value of that, you will find avenues to sort of be
Engage.
involved with academics. To continue to be able to be involved in academics, one of the most important things is that you need the reciprocation. So you need people who are also interested.
Mm.
You need people who also are curious, are wanting to sharpen their skills, and you know get as much as you can from there. So when you see that kind of zest, your interest,
Motivated to keep.
you get
Yeah.
more motivated.
And my final question, if you had to give one piece of advice to a young HPB surgeon embarking on his or her career, what would be?
One, we should have one full session for that.
Okay. And like a gist in a nutshell.
No, no, I'm just kidding. Uh, you know, you would have realized, and many people who get into this realize that HPB is an unforgiving specialty. Today you did a good surgery and you feel now I've arrived. And then the next day or another day, the disease will challenge you and defeat you. So you have to realize that it's a challenging specialty and you should be prepared to do the long hours and the hard work. But I also tell people that you should be like a sponge. When you are there, just absorb everything, because training and teaching doesn't come in classrooms or in didactic methods of imparting education. So every day when you are doing something, you you get
You
something
learn something.
from it. You learn that. The second part is that you need to be passionate and you should strive to excel. If that s- drive to excel is not there, then you would be satisfied with anything which comes your way. But it's always you need to sort of, you know,
Raise the bar.
raise
And
the bar and make it up to that every time that you do or embark on anything. So
well, thank you, sir. It's been a fantastic session, so enlightening, and thank you for all your anecdotes and all the experiences that you shared with the audience. I think anyone and everyone who's heard it will greatly have benefited. So, thank you.
thank you, Gayatri. Now I take it back. Now I take the show back. Uh, so thank you for doing this, and I wish you all the best.
Thank you, sir.
And thank you very much for taking time off from your busy schedule and doing this
Yes, sir. It was
for
a
me.
pleasure. Thank you.